Hello and welcome to the Helen Rey Breast Cancer Research Foundation Annual Patient Appreciation Event, presented this year as a webinar due to the global coronavirus pandemic. The goal of today's presentation is to express my appreciation to clinical trial participants by thanking them for their contribution and commitment, and by sharing with them the progress of the clinical trials in which they participated. I also seek to update everyone about the status of ongoing clinical trials and to inform you about clinical trials that are under development. Now, before I begin, we should start with the basics. What are clinical trials? Clinical trials are research studies involving humans that aim to evaluate new treatments, procedures, or tests for the purpose of detecting, treating, or managing a health condition. Despite the importance of clinical trials, a large majority of patients or people have not participated in clinical trials, with only about 10 to 20% of adults reporting clinical trial participations by themselves or by a member of their family. However, through my own research, I have determined that the main reason more people don't participate in clinical trials is that no one ever asked them to. Now, among those who are motivated to participate in clinical trials, the top reasons for choosing to participate in clinical trials include the following: a desire to advance medicine, to help improve the lives of others, to help improve my condition, to earn money, and to receive free medical care. However, a major option that's missing from this list of options is a desire to access innovative treatments, particularly those that are only accessible within the clinical trial. And that's where I found my sweet spot as a breast cancer surgeon and cancer researcher. You see, there's this notion of standard of care, which is the basic concept of practicing medicine or surgery within well-established guidelines. However, we will never experience progress if we only do what we've always done. In my opinion, the standard of care is the floor, not the ceiling. And it is through innovation that we continually raise the standard of care to achieve better and safer treatment options. And that, in a nutshell, is what we're trying to accomplish with the Helen Rey Breast Cancer Research Foundation. The mission of the Helen Rey Breast Cancer Research Foundation is to expand access to innovative approaches that reduce the side effects and burden of breast cancer surgery, reduce the burden and side effects of breast radiation, reduce the side effects and burden of lymph node surgery, and improve the overall breast surgical recovery experience. The Helen Rey Breast Cancer Research Foundation is named after Mrs. Helen Rey, who lost her sister to breast cancer. She also lost her brother and her dear husband to cancer. Unfortunately, I never had the opportunity to meet Mrs. Rey, but I am tremendously appreciative of the seed funding that she left in her will to support cancer research. Funding of the Helen Rey Breast Cancer Research Foundation was made possible by Mrs. Rey's niece, Irma Borneo, and Irma's best friend, Carmen Fisher, for whom I am very thankful. The Helen Rey Breast Cancer Research Foundation is a 501c3 tax-deductible nonprofit organization with 100% of contributions going to research and research-related activities. The foundation operates under the leadership of myself, Irma Borneo, the treasurer, and Carmen Fisher, the secretary. The day-to-day activities of the foundation are accomplished currently with the assistance of Allison Zimmerman, my research coordinator. She is also an aspiring medical student whose position is partially funded by the foundation. We also rely heavily on the assistance of Alba Gonzalez, whose research-related activities are entirely funded by my practice, not by the foundation. Alba is primarily responsible for coordinating appointments and procedures. As with Allison, one of my personal missions is to provide an opportunity to give aspiring doctors an opportunity to get involved in medical research. 3 such individuals are Ronald Rivera, Alexandra Banks, and Gerald Coronado, with whom some of you might have interacted in person or by phone. All came to me as college students, and I'm happy to report that Ronald is now an emergency room physician, Alexandra is a medical student in Washington, D.C., and Gerald is currently a medical student in Virginia. I'd also like to acknowledge several of my former nurse coordinators, America Casillas, Jackie Major, and Monica Denarier. Now, one of the most important take-home messages from this presentation, and in fact, the main thing driving my approach to medicine, is the concept of patient-centered care, which is defined by the Institute of Medicine as providing care that is respectful of and responsive to individual patient preferences, needs, and values, and ensuring that patient values guide all clinical decisions. Patient-centered care takes into consideration tumor biology, tumor extent, and available treatment options, and then uses that information to customize a treatment approach that balances the patient's desire to treat her cancer against her willingness to tolerate the risks of treatment. For some patients, when we talk about cancer treatment, they justifiably or unjustifiably hear the following. The good news is that we can cure you. The bad news is that the cure is worse than the disease. Such was the case for this young woman who sadly died of breast cancer at the young age of 37, who feared a diagnosis of breast cancer and its potential treatment so much that she allowed a small cancer that could have been treated early and very effectively to grow into one that required the very things that she feared: mastectomy, chemotherapy, and radiotherapy. After she passed, I had the opportunity to attend her funeral, where I got to learn some things about her that I had not known. Turns out, she had been considered by many to be their best friend. She was always the life of the party. So for someone so full of life and potential, the loss is even more tragic. But her passing has not been in vain, because she is one of a number of similar patients who have helped to make it my mission to bring hope to the diagnosis and treatment of breast cancer by developing and expanding access to treatment options that reduce the physical and psychological burden of breast cancer care. By making it possible to select a treatment that best suits their personal circumstances and tolerance for risk. Indeed, this reflects the emerging trends in the field of breast oncology, involving expanded treatment options that may be modified based upon the patient's tolerance for risk, targeted in that treatments can be customized based upon an individual's specific tumor subtype, less invasive in terms of the extent of surgery required, less morbid in terms of the degree of collateral damage, less burdensome in terms of having less impact on the quality of life, and increasingly more cosmetic. So, at least in theory, we should be able to dial up or dial down the treatment based upon the patient's individual circumstances. But customization of personalized care is only possible if we have a range of treatment options, and that is the mission of the Helen Rey Breast Cancer Research Foundation, to develop and promote effective but less invasive, less burdensome treatment options through cancer research and cancer clinical trials. In fact, you can visit this page at Helen Rey Breast Cancer Research Foundation.com to see some of the projects that we have underway, as well as to look at some of the projects that have been completed. For the remainder of today's presentation, I'd like to focus on 3 projects that you could read about at the Helen Rey Breast Cancer Research Foundation website. The first is the Target Intraoperative Radiotherapy trial, which was recently completed and published. The second is the Frost Cryoablation trial, which is ongoing. And the third is the DCIS, or ductal carcinoma in situ cryoablation breast cancer prevention trial, which is a new trial that I'm trying to get funded. First, we'll start with the Target A intraoperative radiotherapy trial. I first learned about intraoperative radiotherapy in 2002 when I attended a boutique meeting in Italy when I had the opportunity to meet Dr. Umberto Veronesi, considered by many to be the father of modern medicine and who played a major role in migrating women out of the dark ages of radical mastectomy. Dr. Veronesi had just launched a study investigating this device for giving radiation to the lumpectomy cavity at the time of lumpectomy. Having heard from my own patients their complaints about radiation, I decided then that IRT was something I'd like to offer. Unfortunately, this particular device was not available in the U.S., so I could not engage or join Dr. Veronesi in the trial that he had already undertaken. However, I soon learned that two other researchers, Dr. Jay Vadia and Dr. Michael Baum from the University College London, had also embarked upon a research study involving intraoperative therapy using a system that was in fact available in the U.S. The technology available in the U.S. is called the Intrabeam system, which was originally developed for treatment of brain tumors, in which the tip of the device was inserted into the brain to treat a very specific area with radiation. For treatment of brain cancer, the system comes with applicators that are used to conform the breast tissue to the radiation source. Here's a close-up view of the radiation source, which uses electricity to generate X-ray radiation from the tip of the device. Here's a picture of the device positioned within the lumpectomy cavity during the delivery of intraoperative radiation. The effectiveness of intraoperative radiotherapy was studied in the Target A trial, which asked the question, can targeted intraoperative radiotherapy achieve local control comparable to traditional radiation, which is usually administered over several weeks? The study was a randomized controlled trial comparing targeted intraoperative radiotherapy in women undergoing lumpectomy with stage 1 or early stage 2 invasive ductal carcinoma. Half of the participants were assigned randomly to receive intraoperative radiotherapy using the target method, which delivers intraoperative radiotherapy in a single fraction or single dose to the lumpectomy site at the time of surgery. The other half were randomly assigned to receive traditional 6-week course of daily radiotherapy delivered to the entire breast after recovering from surgery. Now, nearly all of the evidence supporting the benefits of radiation therapy following breast conservation are based upon women receiving radiation to the entire breast in 4 to 6 weeks of daily treatments administered after surgery in the radiation oncology department. This has been an effective treatment, but it's one that has been associated with significant inconvenience and treatment noncompliance, especially for women living greater distances from the radiation oncology center, some of which may simply choose to undergo mastectomy to eliminate the need for daily radiation treatments. Now, when targeted intraoperative radiotherapy is initiated, low voltage X-rays are delivered directly to the walls of the lumpectomy cavity, followed by quick attenuation or the falling off of the strength of the dose as the X-rays travel farther from the source. This loss of strength effectively spares more distant tissues the effect of radiation. Here's a graph of study enrollment showing the first enrollment in the year 2010. I joined the trial in 2006 after working for several years with hospital administrators to acquire the radiation system needed to participate in the trial. As you can see, the last patient was enrolled in the year 2010, and then all patients were followed for long-term outcomes. As some of you know, I left USC in 2011, and following my departure, USC did not commit to maintaining long-term follow-up of patients enrolled at USC. Fortunately, we can thank the Helen Rey Breast Cancer Research Foundation for funding the coordinators that were needed to maintain long-term follow-up of patients that were actually enrolled at USC in the target trial. Without that follow-up, we would have been unable to provide an accurate report of long-term outcome data in this trial. I'm happy to present this image of the publication reporting the long-term outcomes of the Target A trial, published in June 2020. And as you can see, I was one of the co-authors of the publication. This slide shows my co-investigators from 33 centers in 11 countries with whom I've collaborated over the last 15 years, a truly international effort. So let's get to the study results. The next two slides summarize the patient and tumor characteristics of study participants, showing that most of the patients were over the age of 60, although 40% of the patients were under the age of 60. 80% of the tumors were smaller than 2 centimeters. 80% of the tumors were low to intermediate grade, but 20% were high grade. 80% of the patients were node negative. 90% were ER positive. 80% were PR positive. 15% were HER2/neu positive. 70% of the patients had screen-detected breast cancer, meaning that their cancers were diagnosed by mammography. 80% of the patients were compliant with anti-estrogen therapy, and about 20% of the patients required chemotherapy. Basically, these characteristics mirror the typical breast cancer diagnosed today with screening mammography. Now, the main goal of the trial was to compare the length of survival without a recurrence within the breast, what we call the local recurrence-free survival, comparing targets shown here as a red curve against external beam radiotherapy or traditional radiotherapy shown here as a blue curve. And what you see is that the curves are virtually overlapping with no statistical difference seen between the two treatment options. This slide compares the two treatments in terms of the patient's survival without recurrence outside of the breast, such as in the liver, bone, or lung. We call this distant disease-free survival. Here too you see no statistical difference between those who received targeted intraoperative radiotherapy, the red line, versus those that received external beam radiotherapy or postoperative radiotherapy, the blue line. Again, no difference between these two groups in terms of their distant disease-free survival. This slide specifically looks at those who live without a recurrence of breast cancer anywhere within the body, what we call the breast cancer specific survival. Here again, you see no statistical difference between the two graphs, the red graph and the blue graph. Now we'll look at the overall survival, which refers to the survival without dying of any cause. Again, you see no statistical difference between the two treatment options. In fact, the only situation where we observed a significant difference between the two treatment options was in the non-breast cancer mortality, or the rate of death from causes other than breast cancer. Here we found a higher rate of heart attacks and lung cancers, shown here as this higher blue curve, in women receiving traditional radiotherapy compared to target, thus proving that target is safer in terms of avoiding injury to the heart and lung. Here's a summary of the Target A trial results comparing 10-year outcomes between the two treatments, showing equal results for all endpoints except for deaths from other causes, which were higher for traditional whole breast radiotherapy. Separately, we have published results showing that IRT is safer in terms of side effects on the breast, that it is associated with lower healthcare costs, and that recipients of IRT show improved quality of life compared to traditional whole breast radiotherapy. What is personally satisfying and what should be gratifying for the patients who participated in the Target trial is that collectively we have witnessed a profound change in the treatment of breast cancer in our lifetime, that we were the agents that made that happen. This reflects the power of an idea, of imagination, of dedication to research, and I am forever thankful for the trial participants for their commitment to this, for their willingness to be contacted 5 and 10 years after the treatment to provide data about how they were doing so that we can report out their long-term data accurately. Because of this effort, RT is now widely available in the U.S. and abroad. And I also want to just make the point again that I'm thankful to the Helen Rey Breast Cancer Research Foundation, because without its continued support of patient follow-up, we would not have collected the data that were required, needed, and really needed to publish accurate long-term data, such as what we have produced in the recent publication of the trial results. Let's now turn our attention to cryoablation. Like intraoperative radiotherapy, I first recognized the potential of cryoablation in 2003. At that time, breast cryoablation was relatively new, and at the time it was only approved for treatment of benign breast tumors. But I had the vision that it would one day be used to treat breast cancers, and I set about the task of learning how to perform cryoablation so that I can one day offer cryoablation as a breast cancer treatment option to my patients. Cryoablation is the use of extreme cold temperatures to destroy tissue, and the name comes from the word cryo, which means icy cold, chill, or frost, plus ablate, which means to remove. So essentially, with cryoablation, we're using a very cold temperature to kill or remove a living tumor. This brief video shows how cryoablation works, beginning with formation of ice crystals within the cancer cells, which may cause injury or disruption of the cell membranes. Extracellular freezing also occurs, where the ice crystal formation between the cells dehydrates or lowers the water content in the extracellular spaces. This draws water from the interior of the cell, which causes the cells to shrink. Shrinking of the cells may cause injury to the cell membranes. During the thaw phase, water flows back into the cells, causing the cells to swell and rupture. Lastly, freezing causes blood vessels to clot, which deprives the cancer cells of oxygen and nutrition. Although cryoablation was used as far back as 1850, the modern use of cryoablation required technological advancements that enabled cryoablation to be administered using a needle-like probe called a cryoprobe, 2 examples of which are shown here. Other important technological developments involve the development of control units, which enabled liquid nitrogen to be transmitted through the cryoprobe to enable freezing of the tissue surrounding the cryoprobe. In this example, one of the control units, and this here on the right is an image of liquid nitrogen that is placed within the control unit and ultimately channeled through the cryoprobe to cause freezing of the surrounding tissues. This schematic shows how we approach breast cryoablation. Here you see an example of the cryoprobe passing through the tumor, which is shown in red. The central temperature of the tumor at its coldest point is minus 185. The goal is to freeze not just the tumor, but the rim of surrounding tissue, called a margin. We aim for a margin of at least 1 centimeter. Essentially, what we're trying to do is treat the same amount of tissue with cryoablation as we would remove with a lumpectomy. And of course, after cryoablation, there are situations where it's appropriate to add adjuvant therapy, such as radiotherapy and or drug therapy, such as anti-estrogen therapy. Here's just a snapshot of a cryoablation procedure, which is generally performed in the office setting under local anesthetic with the patient awake. And now I'd like to show you an actual cryoablation procedure narrated by me. So if you're squeamish when it comes to needles, you might want to turn away for a few minutes. The first step is to inject local anesthetic into the breast. Here's the ultrasound image with the needle appearing as a white line entering the breast on the left side of the ultrasound image. After the skin is anesthetized with lidocaine, a scalpel is used to make a small nick in the skin. Next, a longer needle is introduced through the skin nick, and additional local anesthetic is injected into the breast. Now you see the needle appearing as a white line entering the left side of the image and then passing between the skin above and the cancer below. The cancer appears as a dark area at the center of the image. In this moment, you see local anesthetic being injected between the skin above and the cancer below. And now the needle is inserted past the cancer to inject local anesthetic on the other side of the cancer. Now you see me holding the cryoprobe as I prepare to insert the cryoprobe through the skin nick under ultrasound guidance. Now you see the cryoprobe appearing as a white line entering the dark cancer from the left. From a different angle, you can see the cryoprobe appearing as a white dot at the center of the cancer. Now back to the original view, with the cryoprobe appearing as a white line entering the left side of the cancer. Fast forwarding a bit, here you see the cryoprobe as a white line fully penetrating the dark cancer, and again from a different angle, appearing as a white dot at the center of a dark cancer. To protect the skin from freezing, they set up a catheter containing saline, which can be injected under the skin to protect it from the underlying ice ball. The first of two freeze-thaw cycles begins. The first sign of ice formation is that the ultrasound image begins to turn dark, initially under the cryoprobe and then on top of the cryoprobe as the ice ball expands to surround the cancer. You see that the ice ball has begun to grow much larger and is now approaching the skin. So it's time to inject saline to protect the overlying skin. Here you see the dark ice ball below and the saline-containing needle entering the left side of the image to inject saline between the skin and the ice ball. At a different angle, you see the saline-containing needle appearing as a white dot at the very top of the round ice ball. Now I'm adjusting the needle position to inject saline into a different area around the ice ball. And you actually see the ice ball move away from the skin as the saline is injected between the two. Here again is the ice ball from a different angle. When the second freeze is complete, the cryoprobe is automatically warmed to permit the withdrawal and removal of the cryoprobe from the ice ball. After a few minutes of pressure, a bandage is applied and the procedure is complete. The first step is to inject local anesthetic into the breast. Here's the ultrasound image with the needle appearing as a white line entering the breast on the left side of the ultrasound image. After the skin is anesthetized with lidocaine, a scalpel is used to make a small nick in the skin. Next, a longer needle is introduced through the skin nick and additional local anesthetic is injected into the breast. Now you see the needle appearing as a white line entering the left side of the image and then passing between the skin above and the cancer below. The cancer appears as a dark area at the center of the image. In this moment, you see local anesthetic being injected between the skin above and the cancer below. And now the needle is inserted past the cancer to inject local anesthetic on the other side of the cancer. Now you see me holding the cryoprobe as I prepare to insert the cryoprobe through the skin nick under ultrasound guidance. Now you see the cryoprobe appearing as a white line entering the dark cancer from the left. From a different angle, you can see the cryoprobe appearing as a white dot at the center of the cancer. Now back to the original view, with the cryoprobe appearing as a white line entering the left side of the cancer. Fast forwarding a bit, here you see the cryoprobe as a white line fully penetrating the dark cancer, and again from a different angle, appearing as a white dot at the center of a dark cancer. To protect the skin from freezing, they set up a catheter containing saline, which can be injected under the skin to protect it from the underlying ice ball. The first of two freeze-thaw cycles begins. The first sign of ice formation is that the ultrasound image begins to turn dark, initially under the cryoprobe and then on top of the cryoprobe as the ice ball expands to surround the cancer. You see that the ice ball has begun to grow much larger and is now approaching the skin. So it's time to inject saline to protect the overlying skin. Here you see the dark ice ball below and the saline-containing needle entering the left side of the image to inject saline between the skin and the ice ball. At a different angle, you see the saline-containing needle appearing as a white dot at the very top of the round ice ball. Now I'm adjusting the needle position to inject saline into a different area around the ice ball. And you actually see the ice ball move away from the skin as the saline is injected between the two. Here again is the ice bowl from a different angle. When the second freeze is complete, the cryoprobe is automatically warmed to permit the withdrawal and removal of the cryoprobe from the ice bowl. After a few minutes of pressure, a bandage is applied and the procedure is complete. The first relatively large-scale study of cryoablation was sponsored by the American College of Surgeons Oncology Group, which in 2009 began enrolling 99 patients with tumors 2 centimeters or smaller in a study in which all patients underwent cryoablation, followed 4 weeks later by lumpectomy or mastectomy to remove the cryoablated tumor. I was a co-investigator in the study, and the goal of the study was to determine if cryoablation would be effective at completely killing the cancer. Patients were enrolled in the study from 2009 to 2013, and in 2016, the results of the study were published in the Journal of Surgical Oncology with me as a co-author. The study found that there was a 100% kill rate for tumors less than 1 centimeter and a 92% kill rate for tumors less than or equal to 2 centimeters. In fact, the failures were predominantly due to the presence of unrecognized disease in the perimeter of the cryoablation site. After the publication of the ACOSOG trial, and with support from the Helen Rey Breast Cancer Research Foundation, I developed and launched the FROST trial, which stands for Freezing Instead of Removal of Small Tumors. The study inclusion criteria were limited to women age 50 and older with invasive ductal type cancers, tumors 2 centimeters or smaller, tumors that were unifocal, meaning that they were present only in one part of the breast, tumors that were ER positive or PR positive, meaning that they were estrogen or progesterone sensitive tumors, HER2 negative tumors, tumors without an extensive intraductal or DCS component, and tumors that were well visualized by ultrasound or MRI, such as the image shown here. Once again, a well visualized tumor by ultrasound or a well visualized tumor by MRI. The FROST trial stratified or categorized patients into 2 groups based on age. Stratum 1, which is age 17 older, and Stratum 2 enrolled women that were age 50 to 69. All study participants were to undergo cryoablation of their breast cancer without subsequent lumpectomy or mastectomy. For women age 17 and older, they undergo no lymph node surgery and no radiotherapy. For women under the age of 70, all undergo radiotherapy, but lymph node surgery is reserved for those determined to have high-risk tumors. After cryoablation, everyone is expected to take 5 years of anti-estrogen therapy, just as they would if they had undergone a lumpectomy or mastectomy. 6 months after cryoablation, all participants are expected to undergo a core biopsy of the original cryoablation site to document complete tumor kill. And then they go on to a 5-year period of follow-up consisting of serial breast examinations and serial breast imaging, including mammography, ultrasound, and breast MRI at regular intervals. Here's a summary of the FROST trial enrollment as of today, showing about equal enrollment in the older and younger patient groups. We still have a ways to go to get to a total enrollment of 210, a problem made more complicated by financial challenges of the sponsor, which did not allow us, due to financial challenges, to open as many study sites as we had hoped. I am currently applying for independent funding to support the completion of the trial. But to show an example of what we've accomplished so far, this is a patient who participated in the trial and has at least 3 years of follow-up. You see a photograph shown here to the left showing the patient post-cryoablation, 3 years post-cryoablation. You can't really tell which breast was treated, but it turns out that it was the right breast that was treated. This is also a mammogram showing pre-cryoablation, the arrow pointing to the tumor before cryoablation. And this is her same breast taken 3 years later, mammography showing the site of the original cancer, but the cancer is no longer apparent, only clips that were placed at the biopsy sites. The next image shows her breast MRI, same patient, same breast. The cancer clearly shown here before cryoablation, and 3 years later, the cancer no longer visible by breast MRI. Although the Frost trial is still relatively young, we can look to Japan for long-term results of cryoablation of breast cancer based upon studies conducted by a good friend of mine, Dr. Fukuma, whom I had the chance to spend time with in Japan in 2009 when I went to learn about his cryoablation experience before I came back to the U.S. to join the ACOSOG trial here in the U.S. Dr. Fukuma recently presented his long-term results of 304 patients treated over 13 years, showing truly remarkable results, a 1% recurrence rate over 13 years. That's as good or better than what we achieved with lumpectomy. Now, it's important to note that all of his patients underwent cryoablation of the tumor, they received breast radiotherapy, they received lymph node surgery, and they also received anti-estrogen therapy. So they did receive all of the expected adjuvant therapy that you would have received, or that they would have received had they undergone a lumpectomy. The only difference is that instead of undergoing lumpectomy, they all underwent cryoablation. But the take-home message is that this study has clearly demonstrated that cryoablation performs as good, if not better, than lumpectomy for tumors that are of the appropriate size and characteristics. In his study, just as with my Frost trial, tumor size is small. His tumor size was 15 millimeters or less, and all of the patients had estrogen-sensitive tumors and no evidence of lymph node involvement. Although cryoablation is a very appealing concept, cryoablation is not for every patient, but neither is mastectomy, lumpectomy, radiotherapy, endocrine therapy, chemotherapy, nor anything else that we currently do. However, the key advantage of cryoablation is that it may serve as an alternative to surgery for certain patients or certain tumors. It may be performed in the office setting in less than 1 hour under local anesthetic and allow a patient to return to normal activities within 1 or 2 days. If you want to learn more about cryoablation, you can visit my cryoablation website at www.cryoablation.com. I want to take a moment to mention this journal article which I published in June of this year. The article was inspired by a number of national guidelines released during the pandemic, for example, by the American College of Surgeons, the American College of Radiology, and the American Society of Breast Surgeons that recommended delaying breast cancer screening and surgical treatment to ease the burden on the healthcare system. In my article, I challenged those recommendations and pointed out that cryoablation, which none of the guidelines had mentioned, could provide a safe and effective way of treating breast cancer during a pandemic, in part because it reduces the need for healthcare equipment and facilities. For example, there's no need for operating room, and it reduces contact with healthcare personnel because it can be performed in an office setting just between a patient and her surgeon. It doesn't require an entire operating room team. Here's a table from the paper which outlines when cryoablation can be used as a definitive treatment and when it can be used as a stopgap measure until the patient may conveniently undergo surgery. Although cryoablation is best suited for small tumors, and specifically small tumors treated on clinical trial, I regularly see patients with larger tumors who continue to decline surgery and possibly other treatments. And for them, cryoablation might be the only option that they're willing to accept. This is an image of one such patient showing a rather large tumor that was clearly too large to treat with a single cryoablation treatment. However, we were able to devise a way of treating the tumor by using not just one cryoablation treatment, but a series of cryoablation. Here you see the same breast with treatment plans showing 4 overlapping cryoablation zones that are used to treat the obvious disease plus a rim of normal tissue surrounding it for a safety margin. The last topic I'd like to present, and perhaps the most intriguing, is a new study that I have yet to launch, but plan to launch as soon as I raise the funding. The title of the study is Impact of Cryoablation on Immune Microenvironment of Ductal Carcinoma in Situ, and its potential for preventing progression to invasive breast cancer. Before I get into the details of the study, first a little background. What is ductal carcinoma in situ, or DCIS? This image here shows the basic breast anatomy. The nipple shown here, milk ducts emanating from the nipple, and lobules, which are where milk is made, shown at the very ends of the milk duct. We're going to now focus on one of the milk ducts and magnify it so that it's much larger. Here you see a normal milk duct lined typically by 1 or 2 layers of cells, and here you see an abnormal milk duct lined by cancer cells, in which all the cancer cells are still confined within the milk duct itself. When the cancer cells are still wholly completely confined within the milk ducts, we call this state of the cancer, or stage of the cancer, ductal carcinoma in situ. The rate at which cancer forms in the milk duct and then progresses to invasive breast cancer varies widely from one individual to the next, but generally begins with some mutations occurring early on, followed by an increase in the number of cells, a condition we call hyperplasia, the formation of atypia, which are abnormal cells not quite meeting the criteria of cancer, followed later by ductal carcinoma in situ, which has not yet developed the ability to spread beyond the breast, and then finally invasive breast cancer, which has developed the ability to penetrate the wall of the milk duct to gain access to the blood vessels and lymphatic vessels, which can then allow it to spread to other parts of the body. From start to finish, this process may take a few years or even decades. So let's look at some of these statistics. How common is DCIS? About 316,700 cases of breast cancer will be diagnosed in the year 2019, and it's estimated about 15% of 48,000 of those will be cases of ductal carcinoma in situ. Do all DCIS lesions grow up to be invasive breast cancer? The answer to the question is no. Based on various historical studies of untreated DCIS, only 25 to 50% of DCIS cases will progress to invasive breast cancer. The challenge is determining which ones will progress and how fast. But in general, we see patterns where some progress fast, some progress slowly, some progress very slowly, and others do not progress at all, at least not within the natural lifespan of the person who has the condition. Now, because of the uncertainty of predicting which patients will progress to invasive breast cancer, over the years, all women with DCIS have been subjected to a number of surgical or radiation treatments ranging from breast conserving surgery and radiation to one-side or bilateral double mastectomy with the goal of preventing progression to invasive cancer. Yet, despite these aggressive treatments, patients may still develop a local recurrence, and when local recurrences develop, half of those local recurrences often come back as invasive local recurrence, even though the original diagnosis was DCIS. So the question is, how can we improve upon these results while also reducing the burden of treating patients with DCIS, particularly those who may never actually progress to invasive breast cancer? Those observations leave you to wonder, is the immune response helpful or hurtful? Based on a number of studies already completed, it appears that DCIS cancer cells are actually able to hijack your immune system to help the DCIS become invasive. You can see that here on these slides. Here's an intact wall of a duct shown here and here. And where invasion is occurring, which is right here and here, you see the highest concentration of immune cells. Again, these brown staining cells, which appear to be concentrated at the part of the duct where invasion is occurring, not at the part of the duct where there's no invasion occurring. So again, the question is, are the immune cells helping or hurting? It would appear that in many instances, these cells are enabling this invasion to happen, essentially creating a path for the invasion to occur. Now, it's important to recognize that not all of your immune cells are created equal. Some are considered good in that they may have an anti-cancer effect, like the ones listed here on the left. But in the context of cancer invasion, other immune cells might be considered bad or harmful in that they may be exploited by the cancer cell to help the cancer cell grow by suppressing the anti-cancer immune response that these cells can create. So if you want your immune system to prevent invasion, we might have to find a way to increase the number of the good or helpful immune cells and lower the number of the harmful immune cells in order to create a situation that will inhibit the progression of DCES to invasive breast cancer. And that's exactly what we're trying to accomplish in this study. The specific aims of which to assess the effect of cryoablation on the composition and expression levels of good and bad immune cells in the microenvironment of DCES, surrounding DCES. The second aim is to assess the systemic immune response to cryoablation of DCES by assessing blood markers of good and bad immune responses. And then, at a much more basic level, since it's never been formally studied, determine how well cryoablation ablates DCES. This study is designed as a 20-patient pilot study of women with large areas of DCES requiring surgery. Prior to surgery, all women will undergo a needle biopsy, followed immediately by cryoablation of the biopsy site. That's represented here. 6 weeks later, they will undergo a lumpectomy or mastectomy. And then, after surgery, the tissue obtained from surgery will be compared to the tissue obtained at the time of cryoablation to determine or make a comparison with how the immune cell composition and activity levels vary in response to cryoablation. We will also look at blood levels of biomarkers or factors at those time points, at the time of cryoablation, at the time of surgery, and then after surgery. The study will also be game-changing in that it will be the first DCIS study to use new technology shown here to study the composition and activity level at the individual cell level, so we can determine which cells are where and what they're doing and how active they are pre and post cryoablation. This technology, canopy chip cytometry and nanostring encounter technology, uses these really sophisticated slides that can allow all kinds of experiments to be run on the slide itself to measure various factors and expression levels of cells. I'm pretty convinced that if we can get this study funded and launched, it will ultimately prove to be another standard of care raising studies that should establish cryoablation as an alternative to surgery, or perhaps as a more effective way of preventing DCES from progressing to or recurring as invasive breast cancer. But the study is yet to be launched. I've been able to raise about $100,000 in in-kind funding, with about $200,000 still needed for tissue analysis using the new technology that I just described. So on that note, I'd like to wrap up this presentation by emphasizing once again that patient-centered care is of prime importance in the management of breast cancer, as well as other health conditions. For breast cancer patients, patient-centered care calls for having treatment innovations that can be adapted to the patient's tolerance for risk, her tumor biology, as well as her tumor anatomy or tumor extent. It calls for clinical trials and willing clinical trial participants that help us examine safer, more effective, and less burdensome ways of treating breast cancer. And it calls for foundations such as the Helen Rey Breast Cancer Research Foundation and general supporters that enable me to bring clinical trials, patients, and researchers together to improve cancer treatment options. If you wish to support the research that I described in this presentation, we welcome your contribution to the Helen Rey Breast Cancer Research Foundation. There are various ways that you can make the donation. They're displayed on this slide. And you can access it through the website as well, helenbreastcancerresearchfoundation.com, donate-here. On that note, I want to thank you all for taking the time to listen to this presentation. It's really a privilege to share this with you, and I appreciate the time and attention given to this discussion. Have a great day.